Okay. So hello and good evening, everyone. Welcome to the 99th Blue Hills Virtual Seminar. Blue Hills Virtual Seminar is a platform that allows healthcare professionals to discuss current management updates of different health-related topics for better patient care. And today's platform is sponsored by Tankara Technologies for the Latent project with Blue Hills Ethiopia. So Latent is a comprehensive platform dedicated to offering valuable information on pregnancy, childbirth, and the initial stages of childhood development, catering to both parents and expectant mothers. Additionally, LearnNet offers the convenience of doctor consultations for individuals seeking professional advice. Moreover, LearnNet features a marketplace that showcases a diverse range of maternity-related products, providing a one-stop solution for the needs of expectant mothers. LearnNet has entered into a collaborative partnership with Blue Hills Ethiopia, with the primary objective of enhancing the expertise and knowledge of LearnNet's medical professionals, particularly focusing on the aspects of pregnancy. This strategic alliance is geared towards providing specialized training and upskilling opportunities for doctors associated with LearnNet, ensuring they are well equipped with the latest insights and advancements in the field of obstetrics. So, say a few things about Blue Hills. Blue Hills Ethiopia is a medical consultancy company founded by medical doctors and a computer engineer, and we aim to be an influential healthcare leader in creating a skilled community through easily accessible knowledge in preventive medicine. I'm your host, Dr. Iheno Taddala, a general physician and first aid trainer from Blue Hills, Ethiopia. Today, it's a pleasure to have Dr. Dawit Mesfin here with us to have a presentation on abnormal labor. Dr. Dawit Mesfin has previously given lectures on previous topics related to pregnancy on our platform, which will be accessible on our YouTube channel, like normal labor, nutrition in pregnancy, and also the danger signs of pregnancy. So for those of you who don't know Dr. Dawit Mesfin is an obstetrician and gynecologist. He is also the Assistant Director of Obstetrics and Gynecology Department at Zoditu Memorial Hospital. Doctor, the stage is all yours. Thank you.
Okay, thank you, Doc, for your keen introduction. So basically, as you tried to mention earlier, I have tried to give some lectures priorly. Basically, this one abnormal level will be a continuity of the normal level. So last time we have seen normal labor, and basically we have seen what normal labor means, what are the characteristics of normal labor, and we have seen the stages of labor, the first stage of labor, the latent phase and active first stage of labor, and how we follow patients on the latent and active first stage of labor, and also we try to see what second stage of labor means and how we follow patient the second stage, and we also see after delivery of the baby how we manage the placenta, which is the third stage of labor, and we have seen this thing on our last lecture. So basically, it's important to know what normal labor means in order to understand what is abnormal. So today's lecture will be on abnormal labor. It's going to be a brief discussion of main important topics on abnormal labor. So to start with the presentation, first we need to know what dystocia means. Basically, we expect a normal labor to be which is not a difficult one, which means we have seen last time what possible things could affect the progress of a normal labor, which is a power abnormality, which is related to the mother, and the passage abnormality and the passenger abnormality. So basically, whenever we have difficulties on these three P's, this we call it a dystocia, which is a difficult labor. So difficult labor could be characterized by either arrest of the progress of labor or failure of the progress of labor, or basically the slowing of the slowness of the progress of labor. So anything that is away from the normal cardinal movements of the normal labor will be considered to be abnormal. Okay, so just to mention something about on the last lecture, we have seen what latent first stage of labor means according to Friedman, and later on according to the WHO and other societies of obstetrics. We just get to know what latent phase of labor means, and it was from onset of labor up to 5 centimeters of the cervical dilatation. So basically, what is abnormal in latent first stage of labor will be called prolonged latent first stage. Okay, so we say prolonged latent first stage of labor when for premise, if she stays for more than 20 hours and 14 hours for multigravids. Okay, so this is the cutoff point to say prolonged latent phase for premise and multis. Okay, but basically this was a consideration of Friedman. Okay, Friedman curve. Okay, but in our guideline, basically we don't wait this much. The practical aspect will be 8 hours. Okay, once we diagnosed latent first stage of labor, especially if the woman has rupture of membrane, okay, we don't go beyond 20 hours, or we don't go beyond 14 hours for premi and multi respectively. Okay, so basically we considered 8 hours to be the cutoff point for prolongation. Okay, so especially when a woman has rupture of membrane. But one thing that we need to know is, as we have said previously on our last topic, the major criteria to differentiate latent from active is the rate of cervical dilatation. Okay, so last time we have said when the cervical dilatation start to dilate with a rate of 1.5 centimeter per hour or 1.2 centimeter per hour, it means it is in the active first stage of labor. So that was a cutoff point to say active. Okay, so basically currently we are considering 5 centimeters to be the cutoff point to say active. Okay, and we cut this point because around 74% of pregnant women in labor will enter to active first stage of labor at around 5 centimeter dilatation. Okay, so when we see active first stage of labor, there are two disorders that we entertain in active first stage of labor. The first is protracted cervical dilatation. Okay, and the other one is arrest of cervical dilatation. Protracted means slower progress of cervical dilatation. So we know that in the normal labor, we expect the cervix to dilate 1.2 centimeters per hour in premise, okay, and around 1.5 centimeters per hour in multis. Okay, so basically, if we don't get this amount of rates of cervical dilatation, then it is something that is against the normal progress of labor. So we consider that one slower, which is a protracted cervical dilatation. Okay, the same thing for the descent as well. Okay, we expect 1 centimeter per hour for premise, okay, and 2 centimeter per hour for multis. So if we don't attain this type of descent, okay, we consider it to be abnormal. Okay, abnormal. So there are different causes that could possibly cause this protracted cervical dilatation. Okay, so it could be, as we have said, the 3Ps. Always we should put in these 3Ps into our mind. Okay, protracted disorder, power abnormalities, passenger abnormalities, and passage abnormalities. Okay, so these are the 3Ps that could possibly affect the cervical dilatation. Okay, the other most important problem of the active first stage is the arrest of disorder. Okay, arrest of disorder means if there is no cervical change for more than 2 hours, okay, then it's a complete session, which means completely session of cervical dilatation for more than 2 hours, then we consider it to be arrested. Okay, and the same thing for descent. If there is no descent for more than 1 hour, then we consider it to be arrest of cervical dilatation. So basically, whenever we have these two things, protracted disorder and arrest disorder, we don't rush for cesarean section, or we don't rush for augmentation and induction. Okay, basically we need to search for the cause for protracted disorder, and we need to search for the cause for arrest disorder. Okay, so based on the cause, for example, let's say um, the cause for protracted disorder is macrosomia. Okay, so basically we're not going to augment a baby with macrosomia because there is a risk of uterine rupture, other maternal complications. So basically that's an indication for cesarean section. So basically if the problem is related to power abnormalities or maternal effort, okay, then at that point we may need to uh, give some kind of erythrotonic agents like oxytocin. Okay, so basically whenever we diagnose these active abnormalities and arrest disorder, protracted and arrest disorders, we always need to search for the cause for protraction and the cause for arrest. Okay, so whenever we talk about the dystocia, as we have said previously, we need to always consider the three P's. Okay, so the first P is called power abnormality. Okay, power is related to the maternal pushing effect or maternal effect. Okay, so there are power basically means contraction. Okay, what will affect the contraction. Okay, so there are different abnormalities that are related to the uterine contraction. We call them uterine dysfunction. Okay, uterine dysfunction. So from the power, in this lecture we are going to discuss on uterine dysfunction. And the other problem that we see is a passage abnormality. Basically, passage abnormality means the canal problem with the genital tracts or where the baby is going out. Okay, so if there is any abnormality on the pelvic bone, okay, like related to CPD, contracted pelvis, or any soft tissue tumors, dystocias, okay, over the vagina or the cervix, okay, or any tumor previa like tumor previa related to leiomyoma and so on, could cause passage abnormality, okay, where the baby could not pass through the birth canal. Okay, so one of the problem is the passage abnormality. So the third one is the passenger abnormality. Basically, passenger means the baby. Okay, so what are the things that could possibly affect the progress of the baby, are whether there is any kind of malpresentation, okay, which is presentation away from the normal presentation. And from the last lecture, we know that the normal presentation is a cephalic presentation, specifically from the cephalic, the vertex presentation or the occipito-anterior presentation is the normal presentation. Okay, so any presentation away from the occipito-anterior presentation is going to be considered as malpresentation. Okay, and the other problem with the passenger is a malposition. Okay, so malposition means the way the head adjusts itself with the maternal pelvis. Okay, or the outlet tract is called malposition. Okay, basically the, as we have said previously, the head has to be occipito-anterior position. That's a normal position of the head. Okay, position of the head. So basically, if we have other way of presentation or positions of the head away from the occipito-anterior, then we consider it to be malposition. Okay, so from these three P's, from the power abnormality, we are going to discuss on the uterine dysfunction, and from the passage abnormality, we will stress on contracted pelvis, and from the passenger abnormality, we'll discuss some points on malpresentation and some points on malposition, and that will be the major area of our discussion from this lecture. Okay, so to begin with the power abnormality, as we have said, one of the major problems with the power abnormality is the uterine dysfunction. Okay, so we do have two types of uterine dysfunctions: the hypertonic uterine dysfunction and the hypotonic dysfunction. Basically, what it means by hypertonic uterine contraction ማለት ነው, the uterus will have regular የሆነ contraction ይኖረዋል. Okay, but that regular contraction will never gonna affect cervical effacement and dilatation. Okay, that is called hypertonic uterine contraction እንለዋለን. when we say hypotonic uterine contraction, the contraction is not regular አይደለም. It is infrequent ነው. Very low amplitude ነው ያለው. Okay? And baseline ራሱ very low ነው. Baseline ራሱ it's very low ነው. Okay? So basically these are the two things that we consider them as uterine dysfunction. Okay, so basically we found hypertonic uterine contraction in a woman with latent first stage of labor. Okay, in latent first stage of labor ላይ ነው ብዙ ጊዜ hypertonic uterine contractionዎች የምናገኘው። እነኚህ ፔሸንቶች they will have infrequent latent እና false labor basically false laborዎች ላይ ነው። Okay, they will have contraction ይኖራቸዋል, but that contraction specifically latent ላይ contraction ይኖራቸዋል, but it will never gonna affect cervical dilatation. Okay, this is what we call it uterine hypertonic uterine dysfunction እንለዋለን። But in case of hypotonic uterine dysfunction የምንለው ብዙ ጊዜ this occurs in women with active phase of dysfunction. Okay, active ናቸው, but the amplitude, the frequency of contraction is somehow infrequent, irregular. Okay, and with low amplitude. Okay, እኛ consider የምናደርገው uterine contraction አለ adequate ነው የምንለው. Basically the woman needs to have at least 3 to 5 contractions within 10 minutes. Okay, and with the standard SI ስንለካው ደግሞ at least 200 to 250 ሞንቴቪዲዮ ዩኒትስ ሊኖራት ይገባል ቤዚካሊ ማለት ነው ስትሬንግዙ። ይህንን አቴን ካላረገች hypotonic uterine contraction እንለዋለን። basically this occurs in active phase of labor ብዙ ጊዜ hypotonic. Okay, there are certain causes that could cause hypertonic uterine dysfunction. ብዙ ጊዜ on general anesthesia ላይ የሆኑ or regional anesthesia, prolonged labor, CPD or uterine rupture, choriamnitis, dehydration or excessive uterine distension secondary to polyhydramnios, macrosomia and everything. Okay, these patients usually they will have this severe type of pain, but that pain will never going to efface or dilate the cervix. Then we consider it to be hypertonic uterine dysfunction. Okay, so basically, for example, for a latent, if she has this kind of problem, we may give her expectant management, we may give her time, or we may give her to rest. For example, for those with false labors, with sometimes you may find in the hospitals people may come, pregnant women came with severe uterine contraction. You check for their cervix, it's closed, okay, but it's very severe type of uterine contraction. So what are you going to do? You're going to give them some analgesics. You're going to give them to rest, therapeutic rest. That's what you should do for hypertonic type of uterine dysfunction. Okay, in case of hypotonic, usually it's occurred in the active phase, as I have tried to tell you. Okay, so the problem here is they are in active phase, but the problem is infrequent, irregular contraction ያላቸው low amplitude ነው። ስለዚህ ይህንን regularize ማድረግ is our main task ይሆናል ማለት ነው። So we have to stimulate them. They stimulate the uterus, which is by basically we have to put them on uterotonic agents like oxytocin. But whenever we try to do these things, we should be able to rule out contraindications like CPD, breech presentation, macrosomia, and other things. Okay, so basically after you rule out these things, you can regularize this hypotonic uterine dysfunction by giving them this uterotonic like oxytocin. Okay, so the next part is about malpresentation. Okay, so whenever we discuss about malpresentation, as I have tried to explain earlier, okay, on the previous lecture, malpresentation means or signifies anything that is away from the normal presentation. Sure? So normal presentation የምንለው it is cephalic presentation ነው። cephalic presentation ማለት በጭንቅላቱ መጣ ማለት ነው አይደለ? but በጭንቅላቱ መጣ ማለት basically በጭንቅላቱ ሲመጣ it could appear with a vertex, with the occiput, or it could appear with a face, or it could appear with a broad presentation. Okay, so we have to be able to know what is normal cephalic presentation. Okay, so cephalic presentation 96.8% to accompany ያደርጋል. But among this cephalic presentation, we do have this face presentation, we do have these broad presentations. Okay, so these are included under this cephalic presentation, okay, which are considered to be abnormal presentations or malpresentations. Okay, the other way that a baby could come with some kind of upper extremity. Okay, so the face could come with a hand. Okay, that's what we call it, a compound presentation. Okay, the compound presentation. And other malpresentations that we usually could find is a transverse lie. Okay, transverse lie. Basically, we do have three types of lie. Okay, lie means basically the longitudinal axis of the baby in relation to the mother. Okay, ልጁ ከእናትየው አንጻር እንዴት ነው የተቀመጠው የሚለውን አሰስ የምናደርግበት ወይ ኢትስ ኮልድ ላይ እንለዋለን። we do have three types of lie. The first one is a longitudinal line. ያ ማለት the baby is basically parallel to the mother. Okay, so that is longitudinal line. If the baby is basically perpendicular to the maternal line, okay, that's what we call it transverse line እንለዋለን። Okay, or if the baby is somehow in oblique, okay, in oblique either breech oblique ሊሆን ይችላል or cephalic oblique ሊሆን ይችላል. Basically we call it oblique line እንለዋለን። So we do have three types of line, and one oblique lie and transverse lie are considered to be malpresentations. Okay, usually oblique lie it's unstable line. Unstable line ስንል when a woman has labor, usually it will convert to either breech presentation or cephalic presentation. So usually the transverse lie is the one that we majorly consider to be malpresentation. So among all the presentations, malpresentation is accompanying about 5% of the all term labors, 5% of. And from the malpresentations, breech presentation is the commonest types of presentation, which is around 2.7%. Okay, so coming to breech presentation. Okay, breech presentation means when the baby presented with the caudal part. Okay, the caudal part. So the baby has two parts. The head is called the cephalic pole. Okay, and the breech is called, or the buttock is called, the caudal pole. Okay, so basically when the baby presented with the caudal pole or the buttock, okay, then we consider it to be breech presentation. We do have different breech presentation types. Okay, as you can see on the figure, I hope you are seeing my cursor. Okay, so the first one is called the frank breech presentation. So as you can see on the frank breech presentation, the hip is basically flexed. Okay, the hip is basically flexed, and we're seeing some kind of also the hip, both hips are flexed, and also we are seeing some flexion over the knee joint. The knee joint, it's not as such it's not extended, but somehow semi-flexed. Okay, so we expect flexion at both the knee joint as well as the hip joint. Then we consider this one as a frank or pike position Okay, so the other most important type of breech type is the complete breech. Okay, so as you can see on the complete breech, still there is flexion over the hip joint. Okay, the hip joint is flexed, and also there is flexion over the knee joint. So on the frank, one of the knee joints might be flexed, but most of the time they are assumed to be in extended position. But in case of complete breech, there is flexion both at the hip joint as well as at the knee joint. So whenever you palpate while you are doing the digital PV examination on frank breech, what you are going to palpate is going to be the buttocks. Okay, so there is no extremities that you are going to palpate. But in case of complete breech, okay, whenever you do digital examination, you will be able to palpate the buttock as well as at least one or two of the extremities. Okay, that's what complete breech means. Complete breech means at least palpate የምናደርገው በተኩና ኤክስትሪሚቲውን palpate እናደርጋለን ማለት ነው። Okay, but in frank breech more or less completely palpate የምናደርገው በተኩን ይሆናል። extremity ምንም palpate አናደርግም ማለት ነው። Okay, so the other type of breech is called the incomplete or footling breech. Here, as you can see on the picture, okay, the hip joint is somehow extended, okay, and as well the knee joint is also extended. So basically, whenever we do PV examination, what we are going to palpate is going to be not the buttock, rather the feet. Okay, the feet is going to be the ones that we are going to palpate. Okay, either 1 feet or 2 feet basically are going the initial part that the initial presenting part that we palpate is going to be the feet. Okay, the feet. So these are the major types of breech presentations, but there is some rare type of breech presentation which we call it the knee presentation. Okay, knee presentation means the baby might present with the knees, okay, not the buttock, okay, flexed at the knees, okay. So whenever we do digital examination, then we are going to palpate the knees, not the buttock or not the actual foot, okay. So these are the three types of breech presentations that we entertain. As we have tried to explain earlier, one of the major among the malpresentations, the commonest types of malpresentation is a breech presentation, which account for 3 to 4%, basically 2.7%. Okay, so the other one, as you can see on this slide, is the incidence of breech. Okay, ያው ብዙ ጊዜ ኤክስፔክት የምናደርገው ምንድን ነው ብሪች gestational age በጨመረ ቁጥር okay as gestational age goes we expect breech to be coming to the normal presentation or cephalic presentation ይመጣሉ ብለን assume እናደርጋለን okay but when you see the part of the breech እዚህ ጋር ብታዩት ለምሳሌ ልጁን ብታዩት the smallest part is going to be the head now okay the major part will be the buttock እና the extremity area ነው ስለዚህ uterusን ደግሞ ስታዩት basically the upper part is called the fundus which is more or less the wider part ነው ስለዚህ ፈንደሱ wider ከሆነ አካምፓኒ ሚል መያዝ የሚችለው የልጁን በተክና ኤክስትሪሚቲ ነው rather than the head አይደለ so basically under normal labor we expect as gestational age በጨመረ ቁጥር the buttock part the extremity part will be confined to the fundus area confined ይሆናሉ ብለን assume እናደርገው and the head will be down to the lower uterine pole ይሆናል ብለን assume እናደርገው okay so as you can see the incidence of breech okay ከ28 ሳምንት በፊት ያለው የብሪች number it's around 20 to 25% ነው so as you go up to 32 weeks to term that number is going to go down to 3 to 4% okay so basically breech is going to be lesser when the woman is going for term okay is going for term okay so there is one picture that you can see up on the slide okay this is things that we see whenever we do PV examination okay so the most important it's very difficult sometimes difficult ሊሆን ይችላል face presentation እና breech presentation መለየት ሊከብደን ይችላል አንዳንድ ጊዜ በፒቪ ኤግዛሚኔሽን ኦኬ so the one that you see here cursor ያለበት ቦታ የምታዩት it's called face presentation ነው and this one is called breech presentation ነው ስለዚህ ፒቪ ስትሰሩ ብዙ ጊዜ ኮንፊውዝ የሚያደርጋችሁ the orifice the mouth could be confused with the anus okay ፒቪ ስታዩ ኮንፊውዝ ሊያደርጋችሁ ይችላል ብዙ ጊዜ እና you might say this breech presentation is face presentation ብላችሁ confused ልትሆኑ ትችላላችሁ so there are certain things that you need to consider whenever you are having a dilemma between face presentation and breech presentation so breech presentation ላይ there is ischial tuberosity አለ bone አለ እዚህ ጋር ischial tuberosity አለ and in between there is anus አለ so basically these three things makes a straight line okay እዚህ ጋር ምን አይነት ላይን ነው straight line ነው basically የሚፈጥሩት straight line ይፈጥራሉ okay basically straight line ይፈጥራሉ ማለት ነው but whenever we consider face presentation the mouth and we do have zygomatic prominence አይደለ እዚች ጋር so the mouth and the two zygomatic prominences basically will create some kind of triangle okay so that's the only way that we could be able to differentiate face presentation from breech presentation okay the two bones on our faces the prominent bones are the zygomatic bones okay and the mouth okay so these three things will create some kind of triangle in case of face presentation but in case of breech presentation okay the ischial tuberosities and the anus will have a straight line okay so by that we may be able to clear out the confusion okay The other thing is, whenever we are considering these three breech types, the frank breech, complete breech, and footling breech, okay, their overall incidence is frank breech is the most prevalent type of breech, okay, and whenever we see the issue of cord prolapse, እግሩ በወጣ ቁጥር or ክፍተት ባገኘ ቁጥር the risk of prolapse will be higher። ስለዚህ እግሩ የሚወጣው ኮምፕሊት ላይ እና ፉትሊንግ ላይ ነው። ስለዚህ ስፔሻሊ ኦን ፊትሊንግ the risk of cord prolapse is around 15 to 18% ይሆናል ማለት ነው። Okay, so these are the things that you need to give emphasis, specifically the incidence of breech as compared to gestational age. Okay, and why is breech not common during term የሚለው ራሱ መመለስ መቻል ይኖርብናል ማለት ነው። Okay, and the other thing is ብዙ ጊዜ ብሪቾች ላይ ማወቅ ያለብን ነገር ምንድነው? Yeah, basically we can be able to diagnose physically breech by the one I showed you with a straight line and with triangular pattern ማወቅ እንችላለን። The other one, that is physical examination. The other one is with using the ultrasound. Okay, we can be able to detect the presentation ማለት ነው። Okay. Okay, so there are specific risk factors that are associated with breech presentation. Okay, these are the major risk factors that you should be able to entertain whenever you have a breech. Okay, always check for uterine anomalies. Okay, specifically those anomalies with bicornate uterus and septate uterus. Okay, they are at risk for uterine, at risk for a baby to be in breech presentation. Okay, and the other one is space occupying lesion, specifically myomas. Okay, myomas, specifically intramural myomas, might make the baby to change space, to change its presentation. Okay, and placental abnormalities. The major one is placenta previa. Okay, so the lower polu ተያዘበት ማለት basically the baby will change its presentation, definitely, most of the time. Okay, and multiparity, okay, because laxed uterus ነው የሚሆነው. Okay, that laxed uterus makes room for the baby to go here and there. So multiparity is another major risk factors. And extremes of amniotic fluid volume, ለምሳሌ those with polyhydramnios ያላቸው, okay, the baby will have ample space to swim here and there, so it will attain some malpresentations. Okay, contracted maternal pelvis, prior cesarean sections, and fetal anomalies. Okay, like for example anencephaly, hydrocephalus, okay, and teratomas like neck masses, sacrococcygeal teratomas, and so on. Okay, these also are considered to be fetal anomalies that possibly could change the presentation of the baby. Okay, crowding, like in case of twin pregnancies, triplet pregnancies. Okay, we don't expect the baby to come with cephalic. It might come with transverse, like shoulder presentation, or it can come with breech. Okay, neurologic impairments, short cords, okay, and prior breech deliveries, okay, are also a risk for breech presentation. Basically, prior commonest is prior breech deliveries. Okay, if the woman has one breech presentation on a prior delivery, the risk of having that will be 10% in the current pregnancy. If she has two breech presentations, the risk is going to be 27%. Basically, it means there is something definitely that makes the baby to have that kind of presentation, definitely. So if a woman has prior breech presentation coming with again with breech presentation, okay, definitely we may suspect some kind of uterine anomaly, some kind of abnormality with uterus. Okay, with the uterus. Good. So coming to the management of babies with breech presentation. Okay, usually we need to have experience. Okay, no, everyone could not be able to deliver breech presentation. Okay, like that of cephalic presentation. Okay, there are certain complications that could appear to the baby related to nerve injury, related to fracture of bones, and so on and so on. Okay, so as much as possible, we need to have a healthcare provider who is trained on breech delivery, as well as we need to have a setup with cesarean section, because not all breech deliveries will end up in delivery, okay, in the normal way. So there might be some problems that could necessitate us to go for cesarean section. So as much as possible, um, um, there should be healthcare facility with equipped cesarean section, okay? And we need to have a healthcare provider experienced in delivery of these breaches, okay? And usually, if the woman has breach before 36 weeks, okay, we don't need to intervene it. Okay, we don't need to intervene it, okay, because there is so-called external cephalic version, which means rotating the baby to its normal presentation externally, okay. That is going to be undertaken by giving the woman analgesics, okay, or some sedatives, okay, so that she's not going to feel pain, okay, in a gentle manner under possible indications, by ruling out contraindications, okay. So usually we perform ECV የምንሰራው ወይም ልጁን ከብሪች ወደ ሴፋሊክ የምናመጣው ወይም ከትራንስቨርስ ወደ ሴፋሊክ የምናመጣው ኦኬ ኮንትራኢንዲኬሽኖች ለምሳሌ ስካር ሊኖራት አይገባም፣ ፕላሴንታው አንቴሪየር መሆን የለበትም፣ የመሳሰሉት ፕሮብለሞች ኦኬ ኦሊጎሃይድራሚነስ ሊኖር አይገባም። እነኚህን ነገሮች ሩላውት ካረግን በኋላ እና 36 ዊክስ ከደረሰች በኋላ መሆን አለበት። አትሊስት ተርም መድረስ መቻል አለባት። Otherwise, if we do this ECV prior to 36 weeks ከሰራ ነው, the tendency to return back to breech presentation or to return back to transverse line is going to be higher. Okay, so as much as possible, always, okay, we perform ECV after 36 weeks of gestational age. Okay, so CS is going to be absolute የሚሆነው መቼ ነው? If there is placenta previa, okay, cephalopelvic disproportion, okay, any other factors associated, ለምሳሌ multiple pregnancy, post-term, preemie-gravid, okay, preemie-gravid currently it's an X factor, okay, usually currently it's not, according to some Society of Obstetrics, they're currently not recommending preemie-gravids with breech not to deliver vaginally, okay, so cesarean section is somehow relative indication to do cesarean section for those with preem with breech, okay. RH isoimmunization to decrease the issue of fetal-maternal transfusion, okay. So the other is elective cesarean delivery could be decided, okay, could be decided at 39 weeks as any other elective cesarean section, okay. So this is how we should, the things that we need to consider whenever we are assessing a breech for delivery, okay. So አንዲት እናት ብሪች ያላት እናት ለመውለድ ፌቨረብል የሚያደርጓት ነገሮች ምንድን ናቸው? እነኚህ things that favor vaginal breech delivery, okay. So the first thing is adequate maternal pelvis. Adequate maternal pelvis ስንል the woman need not to have contracted or CPD ሊኖራት አይገባም, okay. So the passage has to be favorable for the baby to pass through, okay. And the other one is the neck has to be flexed. The neck has to be flexed, okay. Hyperextended neck, okay, is a risk for entrapment, okay. So always እዚህ ጋር የምታዩት for example እዚህ ጋር የምታዩት head, this head has to be somehow flexed መሆን አለበት። hyperextended ከሆነ after delivery of the body, the neck might be entrapped ሊሆን ይችላል። ስለዚህ we don't need the head to be extended. So flexed neck, and the weight has to be between 2.5 and 3.8 kg መሆን አለበት። Yeah, always we need to take consent from the patient, okay, because this is not such an easy procedure አይደለም ሁልጊዜ, okay, ሁልጊዜ እንደ ሴፋሊክ የምናዋልዳቸው ነገሮች አይደሉም። ስለዚህ there could be possible complications associated with breech delivery. ስለዚህ always we need to properly counsel the woman, we need to take consent from the mother, okay. And as I have tried to explain earlier, cesarean section facility, healthcare provider with skill has to be there, okay. And the score, the so-called Zatuchiri Anderson score, it has to be greater than 4 መሆን አለበት። There are scores that we need to take to count, okay. So it's called Zatuchiri Anderson score ይባላል, okay. And after we decide on all these things, okay, we need to have good progress of labor ሊኖረን ይገባል። okay, so normal labor progress የምንለውን okay attain ማድረግ መቻል አለበት ማለት ነው። progress of labor protracted ከሆነ progress of labor arrest ካረገ and then it's an indication for cesarean section ማለት ነው። okay, otherwise these things has to be fulfilled መሆን አለባቸው ማለት ነው። okay, things that necessitate that goes for cesarean section directly frank ካልሆነ okay, I mean frank breech ካልሆነ like incomplete breech or footling breech ከሆነ it is an indication for cesarean section። ለምን? because ከወጣ በኋላ እግሩ ወይም part of the body delivered ከሆነ በኋላ there is a risk for entrapment of the head, which we call it after coming of head እንለዋለን። okay, so basically the head, I mean the foot is not a good dilator of the cervix. okay, ክፍት አድርጎት ይገባል cervixን and then the cervix is going to retract on the neck of the baby. okay, so that is the main reason that we don't allow incomplete or footling breech to deliver vaginally. okay, so and the other thing is poor dilator ከመሆኑ በተጨማሪ ደግሞ there is a risk of cord prolapse። ቅድም እንደነገርኳችሁ ወደ 15% አካባቢ ነው footling breech risk of cord prolapse። ስለዚህ due to this and other factors we don't allow cesarean section for incomplete or footling breech. okay, and the weight most importantly less than 1.5 and greater than 4 kg ከ1.5 በታች ማንመርክበት ምክንያት the issue of proportion of the head to the abdominal circumference. okay, less than 1.5 the head is bigger than the abdominal. okay, so there is a risk of entrapment of the head as well. okay, and ቅድም እንዳለው flexed neck ካልሆነ hyperextended neck ከሆነ or uterine dysfunction ቅድም ያልናቸው uterine dysfunctions ለምሳሌ hypotonic type of uterine dysfunction which is common in active phase of labor. okay, በጣም low amplitude ያለው infrequent የሆነ irregular የሆነ contraction ካላት are we going to augment? No, we are not going to augment patient with breech presentation, a pregnant woman with breech presentation. So it's a direct indication to do cesarean section ማለት ነው። okay, so ቅድም እንዳልኳችሁ ኤክስፒሪየንስ ከሌለው ሰውየው okay prior cesarean delivery ካላት ስኮሩ less than 4 ከሆነ poor progress of labor arrest protraction የመሳሰሉት ነገሮችም ካሉ then you go directly for cesarean section ማለት ነው። okay, so these are three ways of delivery of babies with vaginal delivery. okay, አንደኛው we just let it go, let it spontaneous vaginal delivery ያ ማለት the baby will deliver through the caudal, okay, through the buttock directly, okay, with little assistant ነው እዚህ ጋር የምንሰጠው okay, little assistant እሱም after passing the umbilicus pass ካረገ በኋላ ማለት ነው። ስለዚህ ምንም ሳንስበው ትራክሽን አፕላይ ሳናረግ ማኒፑሌት ሳናረገው ኦንሊ ሌላ ዳሜጅ እንዳይሆን ብቻ ሰፖርት አድርገናል okay በራሱ ዴሊቨር የሚያደርግበት ሜካኒዝም ነው። this what we call it spontaneous vaginal delivery እንለዋለን። assisted vaginal delivery or partial breech extraction የምንለው ደግሞ ምንድነው? the baby will going to deliver spontaneously till the umbilicus ከዛም በኋላ ባለው ፓርት ግን we are going to apply gentle traction. okay, gentle traction apply እናደርጋለን and then assist the delivery of the arms, okay, the hands, and then we'll assist the delivery of the head. okay, always ግን traction apply ስናደርግ it is going to be in coherent with the maternal pushing effort መሆን አለበት ማለት ነው። okay, pushing effort መሆን አለበት። so this is what we are doing while we are doing assisted vaginal delivery. okay, so partially it is spontaneous, partially it's going to be by our assistant, which is breech extraction. okay, and the other one is total breech extraction. In case of total breech extraction, it is going to be us who deliver the baby entirely from the uterus. okay, so we are going to insert our finger basically, and then we are going to decompose the legs as you can see here. በጣቱ እግሮቹን ይዛል፣ እግሮቹን ፍሌክስ አድርጎ ያወጣቸዋል። okay, and then traction, gentle traction apply ያደርጋል and then the rest of the body ያወጣል። ከዛም ይስባል gentle traction and then ወደ ውጭ ሲወጣለት ደግሞ gently እጆቹን ቀስ ብሎ ያወጣል and then finally the head ያወጣል ማለት ነው። this is basically what we call it total breech extraction እንለዋለን ማለት total breech extraction። these things are extremely difficult things. They are associated with complications. Okay, complications. So basically, we shouldn't attempt doing these things if we are not trained or if we are not having this experience of doing extractions. Okay, extractions. Okay. Uh, the next part is going to be face presentation. Okay, so face presentation, as the name implies, when the baby comes with a face, then we consider it to be face presentation. So ቅድም ምናልባት try to mention ላረኩት ኦኬ ብሪችን ከፌስ ፕሬዘንቴሽን የምንለይበት አንደኞቹ ነገሮች ውስጥ ኦኬ ፌስ ፕሬዘንቴሽን ላይ we are going to palpate the mouth and we do have prominent things. Okay, we do have prominent zygomatic bones. Okay, so the mouth, the two zygomatic bones will create some kind of triangular appearance. That's the only way that we differentiate physically from that of the breech. Okay, in the breech we do have two ischial tuberosities. Okay, we do have the anus, and these three things will create some kind of line. Okay, so this line is different from the triangle that we have in the face presentation. Okay, so face presentation ላይ ስታዩት የሚመጣው part okay the face ነው so እዚች ጋር ምናልባት እዚች ጋር ከርሰሪ ትታያችሁ እንደሆነ so the diameter that we anticipate for face presentation is called the segmentobrachmatic diameter. Okay, this is the diameter. Okay, so basically it is 9.5 centimeter. 9.5 centimeter is able to pass through the maternal pelvis. It is possible to pass. Okay, but the problem is how is the baby face present. Okay, so as we have remembered from the cardinal movements of labor. Okay, the first one is engagement. Okay, so once the baby has engaged, okay, then it's going to descend ያደርጋል. Okay, descend ያደርጋል. Then while it meets the mid pelvisun meet በሚያደርግበት ጊዜ mid pelvisun ሲገባ ማለፍ ያቅተዋል። ስለዚህ ማለፍ ስለሚያቅተው ምን ያደርጋል? ፍሌክስ ያደርጋል። Okay, ፍሌክስ ያደርግና ያልፋል። ፍሌክስ ካደረገ በኋላ it's going to internally rotate ያደርጋል። internally rotate ካደረገ በኋላ maternal pelvisun ሲገጥመው okay, the levator ani muscles the perineum በሚገጥመው ጊዜ ደግሞ ለመውጣት ምን ያደርጋል ማለት ነው? it will extend ያደርጋል ወደ ላይ። Okay, so extend ሲያደርግ ይወጣል ማለት ነው። Okay, አሁን in face presentation we do have certain things. The designation point for face presentation is the chin ነው። Okay, the chin or the chinu is a designation point ነው። ስለዚህ አሁን ለምሳሌ እዚህ ጋር የምታዩት ቤቢ the chin is more of anterior ነው አይደል? Okay, we call it mento anterior. Okay, mento anterior እንለዋለን ማለት ነው። Basically the chin is upward ስለሆነ ማለት ነው። If the chin is downward to the sacrum, then we consider it to be mento posterior እንላለን ማለት ነው። If the chin is to the right or to the left, then we say right mento transverse or left mento transverse እንላለን ማለት ነው። So that's how we represent face presentation. So እዚህ ጋር የምታዩት ቤቢ came with mento posterior. Okay, mento posterior ከሆነ አሁን ይሄ ቤቢ ለመውጣት ምን ማድረግ አለበት? ኤክስቴንድ ማድረግ አለበት. But the problem is already the baby is extended. Okay, already is extended. So in this kind of mento posterior type of face presentation, the management is going to be cesarean section because ከዚህ በኋላ ኤክስቴንድ ማድረግ አይችልም ይሄ ልጅ። Okay, but if you consider the mentum here ከሆነ አሁን ይሄ ልጅ this one the mentum is anterior አለ። So in order to go out, just he needs to flex the head. Okay, flex ሲያደርገው and go out to the perineum ማለት ነው። So basically the only face presentation that could be delivered vaginally is the mento anterior face presentation ይሆናል ማለት ነው። So just this is to highlight the figures on face presentation. There are certain risk factors that could possibly lead for face presentation. The one is anencephalus or some type of abnormalities over the head. Hydrocephalus, severe hydrocephalus, neck masses, okay, neck masses, anterior neck masses, nuchal cords, multiple, CPD, prematurity, macrosomia, okay, and contracted pelvis, and some type of maternal pelvis, specifically the platypeloid type of maternal pelvises. Amniotic fluids like polyhydramnios, okay, previous scars, and certain types of races are minor risk factors that could possibly lead for face presentation. Okay, so this figure typically shows a baby born with face presentation. As you can see, the baby's face is going to be impacted into the maternal pelvis. Okay, so it's going to be edematous, and it will have a face like this one. It's the commonest presentation that you are not going to miss it if you see it. So basically, the mouths, the lips, the cheeks, and nose, the eyes is going to be edematous. Okay, so and due to multiple um, PV examinations, you might even see some kind of traumas to the face. Okay, so basically, this is not going to be a long-term consequence for the baby. Usually, after 72 hours, after a week, this edema is going to be subsided and it's going to come to the normal face. Okay, so as I've tried to mention earlier, okay, only the mentum anterior is going to be the one that's going to be delivered vaginally. Okay, why is that? Because mentum anterior, there is a possibility that the neck could be able to flex. Okay, the only thing that needs to deliver vaginally is flexion of the head. Okay, if the baby flexes its head, it's going to go out. Okay, but in case of mentum posterior, already came with extended neck. Okay, so extended neck ሆኖ ከመጣ there is no way that's going to extend more. So it's going to be impacted there. So it's an indication for cesarean section. So mentum posterior is the only face presentation that's going to be delivered cesarean section. Mento transverse, there is a possibility that's going to go up to the mentum anterior or mento posterior. So finally, after it settles, then we decide for cesarean section. Okay. So the other one is called the bro presentation. The bro presentation. Basically, በግንባሩ ከመጣ we consider it to be a bro presentation. Okay. So on bro presentation, the designation point is called the frontum እንለዋለን. So ስንገልጸው either we say frontum anterior, frontum posterior, or frontum transverse ብለን ነው የምንገልጸው ማለት ነው። bro presentation by any means vaginally ሊወለድ አይችልም. Okay. Why is that? Because the diameter for bro presentation is from the chin, okay, up to the occiput, okay, up to the occiput. Basically, it is the longest diameter that a baby could come up with, which is 14 centimeter. Okay, and son በረጅሙ ዲያሜትር የምንለው ፌሱ ላይ ኢትስ ብሮ ፕሬዘንቴሽን ሲመጣ ነው which is 14 ሴንቲሜትር ነው ኦኬ so it's called the mento anterior diameter እንለዋለን so it is 14 ሴንቲሜትር ነው 14 ሴንቲሜትር በምንም ተአምር ቫጂናሊ ሊወለድ አይችልም unless otherwise it tear up the woman okay ካልቀዳደዳት በስተቀር it will never go out through the vagina okay so basically in order for bro presentation to deliver vaginally, either it has to change to vertex presentation, okay? With the vertex መዞር መቻል አለበት, okay? Or ደግሞ it has to reverse back to face presentation, okay? With the face presentation መምጣት አለበት, okay? ስለዚህ በሁለቱ way ከመጣ ብቻ ነው possibility of vaginal delivery የሚኖረው ማለት ነው, okay? So this is the presentation that you need to know. Face presentation ቅድም እንዳልኳችሁ basically 9.5 centimeter no diameter. Okay, so it is possible to deliver vaginally. But in case of bro presentation, due to its diameter, which is the longest diameter, delivery vaginal is not attainable. It's not attainable. Okay, so we have the term called persistent bro presentation. Okay, persistent bro presentation. Basically, we say persistent ነው የምንለው ምንድነው bro presentation ለምሳሌ እስከ 7 ሴንቲሜትር ድረስ it's okay we can follow her okay we can follow the bro presentation but once it reaches to 7 centimeter okay and after 7 centimeter of second stage ገብተው if there is no change ብሮ ያ ማለት ብሮ ወደ ፌስ ፕሬዘንቴሽን ወይም ብሮ ወደ ቨርቴክስ ፕሬዘንቴሽን መቀየር ካልቻለ within 2 hours then we give the term called persistent bro presentation. Okay, and that's an indication for cesarean section ማለት ነው. Okay, cesarean section ማለት ነው. And there is another possibility, okay, with experienced, skilled persons, that a possibility of changing bro presentation to mentum anterior face presentation or occiput anterior position. But if that is not be able to attain, okay, then cesarean section is going to be the only way that the baby could be delivered. Okay. Okay. So the other malpresentation that we are going to entertain is called the transverse line. Okay. So as you can see on the picture, we do have a baby with a transverse line, which is the orientation of the baby is basically perpendicular to the maternal alignment. So this we call it shoulder presentation. Okay, it's called shoulder presentation. It can be back down. Okay, the back could be down, ሊሆን ይችላል, or the back could be the other side, up ሊሆን ይችላል. Okay, so these are the two ways that transverse line could appear. Okay, in the back up position, in the back down position. There is a reason that we need to mention as back up and back down reason አለን. Okay, on the way of management, back downs are very difficult to extract. Okay, specifically when the babies are preterm and back down, extraction is going to be very difficult, and it might end up in extensions, tears, and so on. Okay, so we need to be prepared before we do cesarean section for transverse line. We need to know where the back is, okay, whether it is down or upward. Okay, so it has clinical significance on the management aspect. Okay, and unstable lines. Okay, it's more of unstable line, and because when the woman reaches to term, sometimes has a tendency either to transverse to breech presentation or cephalic presentation. Okay, and the other one is it's called shoulder presentation. By the way, it's called shoulder presentation because, as you can see here, when we do PV examination, the part that we see that we palpate is going to be the shoulder. Okay, this is the shoulder that we are going to palpate. Sometimes we may palpate the ribs. Okay, we may feel some kind of ridge on our finger. Okay, on our finger. So these are the things that we might found on doing physical examination for babies with transverse line. ልክ እንደ ግሪድ ላይን ነው የምናገኘው ወይም ደግሞ ሾልደሩ ነው ፓልፔት የምናደርገው ፒቪ ስንሰራ ማለት ነው። Okay, and the most common risk factor for transverse line is considered to be the prematurity. Okay, so management wise, ልክ ቅድም እንዳወራነው breech presentation ላይ okay, transverse line before 36 weeks there is nothing that we can do. Okay, but after 36 weeks, okay, we can do external cephalic version. Okay, so as you can see on the picture here, okay, the health provider is trying to reverse back the breech to cephalic. Okay, likewise, we can do this external cephalic version to reverse this transverse line to cephalic presentation. Okay, but this has to be done only after 36 weeks by ruling out contraindications. Always we need to be able to rule out contraindications. Okay, contraindications like placenta previa, scar, okay, oligohydramnios, location of the placenta, and so on things. Okay, so we do this cesarean section only if ECVs fail. Okay, ECV fail ካረገብን or basically if she come with labor, okay, ከመጣች and neglected transverse line. ብዙ ጊዜ we use the term neglected, okay, in case of obstructed labor. Okay, the difference between obstructed labor and the difference between obstructed labor and CPD is obstructed labor is basically it is neglected CPD, no, neglected CPD, no. Okay, it shouldn't occur in the setup where obstetric service is being given. Okay, ኦብስትራክትድ ሌበር ማለት ፕሮፐርሊ ሲፒዲን ዳያግኖስ ማድረግ ሳንችል ስንቀርና ኮምፕሊኬሽን አራይዝ ሳያደርጉ ነው። ፎር ኤግዛምፕል this baby that you can see here, okay, initially was shoulder presentation, basically, okay. If we are not able to diagnose shoulder presentation properly, okay, and once the baby's hand has gone prolapsed, okay, and it's going to be impacted, okay, and then that's a so-called obstructed labor, okay. It's an emergency obstetrics, it's obstetrics emergency, basically, okay. And the other one is the other way of management is destructive delivery. Specifically, this can be done with consent and with precautions, whether we having this fully cervical dilated, accessible presenting parts, okay, and we have to be sure that we are going to extract the baby, okay. And experience is also very important because there is a risk of damage to the cervix, damage to the uterus, okay. So always, whenever we are planning to do destructive delivery, experienced hand is very important so that we are not going to damage the uterus and the cervix, and there should be accessible presenting part, okay, presenting part, okay. But the other option is always solved. This cesarean section is also possible, okay. So the other malpresentation that we need to discuss here is about shoulder dystocia. Okay, so as you can see on the figure, okay, the baby's head has already passed, but the shoulder is already impacted here. Okay, it's impacted here. So basically, failure of the shoulder to spontaneously traverse the pelvis after delivery of the head. Normally, head ከወጣ በኋላ within 3 to 5 minutes, we expect the other body parts to deliver. Okay, but if we are not able to deliver the shoulder and the other part of the body within 3 to 5 minutes, then we consider it to be shoulder dystocia. There are different causes or risk factors that could possibly lead for shoulder dystocia. Okay, the major one is diabetic mellitus, specifically GDM in pregnancy. Okay, GDM in pregnancy causes truncal obesity. ያ ማለት ማክሮሶሚክ ብቻ አይሆኑም ልጆቹ, but also there is fat deposition over the trunk. Okay, that's what differentiates from the other macrosomics of non-diabetic women. Okay, ስለዚህ truncal obesity ሲኖራቸው there is a risk of shoulder dystocia ማለት ነው. Okay, and the other one is previous shoulder dystocia ካላቸው on a previous pregnancy, post-term pregnancies, male fetuses for some studies. Okay, maternal obesity, high gestational weight gain, maternal demographic conditions, pelvimetry, okay, and some type of pelvises, okay, are anthropoid, specifically anthropoid type of pelvises. They are considered to be the risk factors for shoulder dystocia. Okay, shoulder dystocia. Okay, so basically the goal of management to prevent complication is there are certain complications that we anticipate whenever we have a patient with shoulder dystocia. So fetal asphyxia is always there, so we have to be prepared for that. Okay, and there are complications that are treated with trying to deliver the baby. Okay, specifically Erb's palsy, okay, fracture like bone fracture, and even trauma to the abdomen while we are trying to push from the suprapubic area. Okay, there are some dangers that we can do over the bladder and so on. Okay, so as much as possible we have to be trained, and always we have to be able to anticipate complications before they appear. Okay, so we need to have risk factors into our minds, and we have to anticipate for shoulder dystocia. That's a major management, that major thing that we need to do. We need to know before we deliver a patient, babies with shoulder dystocia. Okay, so management wise we have different techniques that we do have different techniques of delivery, but always as I have tried to explain earlier, okay, all macrosomias are not the same. Okay, macrosomias secondary to patients with diabetic mellitus and then diabetic mellitus are almost all different. Okay, so the cutoff point that we anticipate delivery for non-diabetic mellitus is 5 kg, okay, and 4.5 kg for diabetic. This is an ideal setups, okay? We're not using this in our standard guideline. In our standard guideline, our macrosomic cutoff point is 4 kg, okay? So, but in the ideal setup, those women with a 5 kg baby, okay, more than 5 kg, we don't need to attempt delivery, okay? And 4.5 kg for diabetic mellitus, okay? So, always we try to deliver babies with shoulder dystocia, we need to give generous type of episiotomy because this type of deliveries might result in perineal injury, perineal tears, significantly third and fourth perineal degree tears. Okay, so as much as possible, we always need to give generous types of episiotomies before we proceed with the maneuvers. Okay, so as you can see on the first maneuver, it's called macroburst maneuver. Basically, the difference between macrobursts with suprapubic pressure is we don't apply suprapubic pressure in order to alleviate the shoulder. Okay, we apply suprapubic pressure in order to alleviate this shoulder. Okay, this shoulder. Okay, but in case of there is another way of macrobert maneuver is just we flex the head, we flex the legs upward, and then we push the suprapubic pressure in order to alleviate this shoulder, okay, the anterior shoulder, okay. Once the anterior shoulder has passed, there will be no problem of delivery of the baby, okay. So basically, while we put pressure over the suprapubic, we are going to increase the length, we are going to increase the diameter, okay, so that the shoulder can pass. And also, we are applying this pressure over the shoulder so that the shoulder can pass easily through the birth canal, okay. And the other is the so-called the delivery of the posterior. እንደምታዩት ሄልዝ ፕሮቫይደሩ ጣቱን ከኋላ በኩል ይገባና የፖስቴሪየር ሾልደሩን ፖስቴሪየር እጁን ያወጣዋል። ኦኬ and then ሮቴት ያደርገዋል። ኦኬ ሮቴት ያደርገዋል 180 ዲግሪ ማለት ቤዚካሊ ሶ እዚህ ጋር ፖስቴሪየሩን ማውጣቱ ስፔስ ይሰጠዋል ወይንም ደግሞ ከላይ ያለውን ሾልደር እንዲላቀቅ ያደርገዋል ማለት ነው። this is one way of delivery of babies with shoulder dystocia, delivery of the posterior arm initially, okay. And the other one is the so-called Robin's maneuver, okay. Robin's maneuver ጋር ምንድነው ልክ እንደምታዩት ሰውየው ጣቱን posterior shoulder ጋር ይሄኛው shoulder ጋር this shoulder posterior shoulder ጋር ከታች ጋር ያስቀምጥና ይገፋዋል basically clockwise dislodge ያደርገዋል ማለት ነው ልጁ and then rotate ያደርገዋል basically rotate ያደርገዋል ማለት ነው okay as you can see on the image okay so look like in the corkscrew ማለት ነው እንደ ብሎን መፍታት ማለት ነው basically ማጥበቅ ነው actually ይሄኛው Robin's maneuver the other way ደግሞ anterior shoulderውን ደግሞ ስናደርገው ደግሞ is called wood screw maneuver እንለዋለን ማለት ነው basically ሾልደሩን ዲስሎጅ ለማድረግ መሞከርና ሮቴት ማድረግ ማለት ነው so these are the major techniques that we practice while we are delivering a baby with shoulder dystocia. So sometimes these all maneuvers can fail up, okay. So there are some techniques, last resources that we can practice, okay. Just replacement of the fetal head and doing cesarean delivery or doing cesarean section na በውስጥ በኩል okay ሾልደሩን ወደ ውጭ እንዲወጣ ማድረግ መሞከር okay and ሲምፊሲስ ፒቪሱን okay ለመክፈት መሞከር under anesthesia ናቸው okay this the first procedure okay and the last procedure they are not as such well practiced due to their invasive nature okay so the other types of presentation that we are going to discuss is compound presentation okay so compound presentation as I have tried to explain earlier okay the presenting parts or will be accompanied by the extremity specifically the upper extremity እጁ አብሮት ሊመጣ ይችላል like this one ማለት ነው okay like this one okay so basically የምናገኘው palpate ስናደርግ we are going to palpate the head as well as the hand the finger okay so early in labor with contraction we can just push the extremity upward okay like early labor ላይ ስትሆን ልክ push ስታደርግ እጆቹን ወደ ላይ መግፋትና ከላይ ሰምዋን ጀንትል የሆነ ፈንዳል ፕሬሸር ሰጥቶ ሄዱ ወይም ሴፋሊክ ሄዱ ወደ ታች እንዲገባ ማድረግ በዛ መንገድ ሪቨርስ ማድረግ እንሞክራለን። ኦኬ that's the usual mechanism of decomposing compound presentation to cephalic presentation. Okay, and as such ሞክረን if it fails and then ultimately we can go for cesarean section again. We can go for cesarean section. Okay, the other part is about malposition. Okay, malposition, as I have tried to explain, it is the orientation of the fetal head in relation to the maternal pelvis. Okay, always baby ሊያልፍ የሚችለው with appropriate amount of diameter pass ማድረግ ብቻ ሲችል ነው። Okay, so the most important presentation, the normal position ብለን የምንጠራው it is the occipito anterior ነው። Okay, any position other than the occipito anterior position is considered to be malposition እንለዋለን ማለት ነው። malposition እንለዋለን። Okay, so basically the occiput posterior position is the commonest types of malposition. Okay, the commonest type. Okay, basically occiput posterior የምንለው if the occiput is down to the sacrum ሲሆን down to the sacrum ሲሆን like the image that you can see here. Okay, here is the occiput. Okay, so it is occiput posterior እንላለን ማለት ነው። So basically this is 11 centimeter now. It cannot pass through this birth canal. In order to pass through this birth canal, as you can see here, okay, it has to be 9.5 centimeter መሆን መቻል አለበት። Okay, so if it goes beyond 9.5 centimeter, like for example here in occiput posterior position, it is 11 centimeter. If this baby delivers through this canal, it will definitely cause some major perineal injuries. Okay, so usually this occiput posterior position, okay, can be delivered in different manners, okay, or can be managed in different ways. Okay, we say we have the term called persistent occiput posterior, which means ሴትዮዋ second stage ወይም fully dilated ከሆነች በኋላ if it stays in occiput posterior for more than 1 hour, okay, then we consider it to be persistent occiput posterior. Okay, yeah, we don't go straight to cesarean section, but we could have some managements. We may try to manually rotate the baby, as you can see here. Okay, occiput posterior basically manually, gently now. This is done under skilled hands. Okay, we are not going to try if you are not because we may damage some nerves, brachial plexus, different fractures to the clavicle and bones as well. Okay, so this is one approach of just rotating the hand, which is called manual rotation. The other is there are specialized types of forceps, specifically the Simpson's forceps, that could possibly aid us both in rotation of the baby's head and traction of the baby's head. Okay, so that could be attempted like this one, as you can see here. Okay, so the other one, if you are not skilled on manual rotation and operative vaginal delivery of this occiput posterior, then we go for cesarean section. That's the safest way to deliver the baby with occiput posterior vaginally. Okay, the other is occiput transverse. Okay, as you can see here, we say occiput transverse because the occiput is in a transverse way. In the left, this one, for example, in the left side of the left occiput side, we call it left occiput transverse. Okay, basically this is common in certain types of pelvis, like in the platypeloid and android pelvis. Okay, so basically we say the same as that of the persistent occiput posterior. We say persistent if it is more than 1 hour in the second stage. Okay, like that of the persistent occiput, there are ways to manually rotate the occiput transverse to either occiput anterior position. Okay, and then to effect delivery. Okay, so there are two types of occiput transverse. First one is the high transverse arrest. High transverse arrest የምንለው ከፕላስቱ ስቴሽን በላይ ሲሆን ነው። ከፕላስቱ ስቴሽን በላይ ሲሆን then we call that transverse arrest to be high transverse arrest. It is in the second stage. Okay, deep transverse arrest የምንለው ደግሞ ከፕላስቱ ስቴሽን በታች ሲሆንና okay, for more than 2 hours, or for more than 2 hours, I mean for more than 1 hour, ኦክሲፑት ትራንስቨርስ ሆኖ ሲቆይ ማለት ነው። ኦኬ ሶ ቤዚካሊ እንደዚህ መክፈላችን the way we apply the management differ ስለሚሆን ነው። ሃይ ትራንስቨርስ ከሆነ manual rotation reasonable ነው, but it may be a little bit difficult because the station is higher. Okay, augmentation if hypotonic uterus ከሆነ okay irregular infrequent uterine contraction ካላት there is a possibility, but still in our guideline for any CPDs on any malpresentations we are not going to augment okay, to be on the safe side. Okay, always we have to be sure that the baby and the mother are safe at the end of the day. Okay, so the other one is cesarean section, which is the safest way of delivery of high transverse arrest. Okay, and deep transverse arrest there is a possibility because the station is lower plus 2 no, ስለዚህ possible to do manual rotation and also possible to do certain types of operative deliveries. Okay, but we should attempt this if she is multi-parous ከሆነች ብቻ። Okay, preemie ከሆነች ግን it's going to be very difficult ስለሚሆን it's better to go for the safe procedure doing cesarean section. Okay, so the other is the last part is understanding about contracted pelvis, and I'm going to finalize the issue. Okay, so in order to understand about contracted pelvis or CPD, okay, we need to know the parts of the pelvis. Okay, the parts of the pelvis specifically, we need to know what the inlet is. Okay, we need to know what the mid pelvis means, and we need to know the outlet of the pelvis. Okay, so these are the most important parts whenever we talk about cephalopelvic disproportion. Okay, and also we need to know the diameters of the pelvis. Okay, so always the inlet diameter, okay, we need to know the anterior posterior diameter. It's very important. Okay, because the anterior posterior diameter is of the inlet is the one that the baby first initially join የሚያደርገው area ነው። Okay, so basically if the anterior posterior diameter is shorter ከሆነ okay, or if it is less than 9.5 less than 10 ከሆነ, and it is what we call it contracted pelvic inlet የምንለው ነው ማለት። ስለዚህ the baby cannot go inside to the birth canal which is contracted. Okay, so basically the most important part in pelvimetry is understanding the diameters of each inlet, mid pelvis and outlet. This figure shows this is the inlet. Okay, this is the inlet. So the inlet, the AP has to be 11 and the oblique has to be 12 and the transverse has to be 13 centimeter. Whenever we come to mid pelvis, okay, all the diameters has to be 12 centimeter and above. Okay, if it is less than this 12 centimeter, there is a risk of contracted mid pelvis. Whenever we talk about the outlets, okay, the anterior posterior outlets has to be 13 centimeter and above, and the transverse has to be less than greater than 11 more or less. Okay, just to have this is to give you the picture of what the inlet has look like, the mid pelvis look like, and the outlets look like. Okay, and the other most important thing that we do for our clinical practice is understanding the obstetric, the true and diagonal conjugates. Okay, whenever we do PV examination, specifically PV sensora, okay, if the sacral promontory, this is the part called sacral promontory መንካት ከቻለን it means it is very short ነው ማለት ነው። okay, it is a sign of contracted pelvis ነው ማለት ነው። PV ለምሳሌ በዚህ በኩል PV ስንሰራ, okay, if we palpate easily these two prominent parts, the ischial spines, then it is a sign of contracted pelvis ነው ማለት ነው። okay, so contracted pelvis ሳይኖቹ ምንድናቸው? አንደኛው easily reachable sacral promontory and easily accessible or prominent type of ischial spines ካለው, or sacrum convergent type ከሆነ, or the pelvic side walls, እነኚህ እዚህ ጋር የምታዩቸው pelvic side walls flat ወይንም ደግሞ convergent type ከሆኑ there are a risk for contracted pelvis ናቸው ማለት ነው። okay, so whenever we talk about the inlet, ኢንሌቱ ሁልጊዜ ቅድም እንዳልኳችሁ ልጁ የሚገባበት ነው። መጀመሪያ ልጁ ሁልጊዜ የሚገባው በትራንስቨርስ ፖዚሽን ነው። ኦኬ ትራንስቨርስ ፖዚሽን ነው which means like this one ነው የሚገባው። ይሄ if you consider this one to be the suture line, okay, የምንፈልገው ዲያሜትር እቺ ነው። okay, this has to be የልጁ ዲያሜትር 9.5 ነው። ስለዚህ የሚገባበት ቦታ at least has to be greater than 9.5 መሆን አለበት, which is AP has to be greater than it has to be greater than 10 centimeter መሆን አለበት። if it is less than 10 which we consider it to be contracted inlet እንለዋለን ማለት ነው። the same thing for transverse and diagonal conjugate እነኚህን ፊገሮች ማግኘት መቻል አለበት ማለት ነው። ስለዚህ before labor the fetal biparietal diameter average has to be ይሄን ያህል ነው። ኦኬ ስለዚህ የፊተሱ ይሄ ከሆነ የሚገባበት ቦታ የሚገባበት አጥንት it has to be which is greater than 10 centimeter መሆን አለበት ማለት ነው። okay that is when we talk about the inlets. okay whenever we talk about the outlet the mid pelvis. okay the mid pelvis is going to be assessed by the interspinous diameter. interspinous diameter ነው የምናየው mid pelvis ላይ። ስለዚህ interspinous diameter less than 10 centimeter ከሆነ we consider it to be mid contracture እንላለን contracted mid pelvis እንላለን ማለት ነው። ስለዚህ ይሄ this is more or less assessed clinically ነው አሰስ የምናደርገው። ቅድም የነገርኳችሁ ischial spine prominent ነው ወይ፣ side wall convergent ነው ወይ፣ sacrum convergent ነው ወይ፣ እነኚህ these are possible signs that could lead us to diagnose contracted mid pelvis before the woman go into labor. okay the other is outlets contracture. outlet የምንለካው ከሁለት ፖይንት ነው ከischial tuberosities. okay these are the two ischial tuberosities. ስለዚህ ከሁለቱ ischial tuberosities ያለው length ነው basically 11 cm expected ነው. okay but if it is less than 8 cm, okay then we consider it to be contracted outlets. ብዙ ጊዜ contracted outlets occur የሚያደርገው ከmid pelvis ነው። mid pelvis contracted ከሆነ possibly the chance of having contracted outlet pelvis is also very high. okay so there are certain physical examinations that we can check for contracture of outlets. okay the first one is the pubic angle. pubic angle acute ከሆነች then we may consider that it is contracted outlets, or basically prominent coccyx. if we found prominent coccyx, it's also a sign for contracted outlets. And knuckle, if this between the ischial tuberosities, okay between these ischial tuberosities our fist should be accommodated. okay እዚህ ጋር our fist has to be accommodated መሆን መቻል አለበት. if it is not capable of accommodating our fist, then we can consider it to be contracted outlets ማለት እንችላለን ማለት ነው. okay this is just a figure that for you to just memorize numbers. Since we are going to share you the slide, you're going to read it. okay thank you all. if you have any question.
All right, thank you very much, Doc. Yeah, I believe there are 2 questions that are posted in the chat box, so we can address them. So one is until you on the chat box, I can read it.
okay yeah I have seen that one. The wood screw and Robin's maneuver, are they the same? So I have tried to explain earlier on the okay so here. okay so here as you can see here, this is a Robin's maneuver. Robin's maneuver, basically we are rotating the baby clockwise. okay in the corkscrew maneuver, it is the reverse one. We are just dislodging the anterior shoulder and then we are rotating in the anti-clockwise wise. Just the opposite of Robin's maneuver is the wood screw maneuver. okay which maneuver is best practically as per our experience for management of shoulder dystocia? Basically, by the way, whenever you are in stress, in tension mode, you may not properly apply the techniques or the maneuvers as you want. So always, whenever you have this kind of obstetric emergencies, the first thing that you should be is you have to be very confident enough and you have to be very relaxed. okay relaxed መሆን መቻል አለባችሁ. and the best practice that usually that we practice is it's a combination. For my practice, for my experience, there is not such one maneuver that we use here and there. okay it's a combination of all practices, but each practice has its own benefit. Each practice is going to be assessed by the experience of the health provider. So uh, uh, for me, it's for my experience, basically, it is a combination. But most of the time, health centers ላይ ሆስፒታሎች ላይ የምታዩት it is a macroberts maneuver, specifically with suprapubic pressure ነው with suprapubic pressure ነው. If the baby is not delivered with this macrobert with suprapubic pressure, then we go for other maneuvers. That's what we basically doing so far. Can ECV be done in breech with two uterus? Okay, so this is quite a unique question, but two uterus means some kind of uterine anomaly. Okay, uterine anomaly. So if there is uterine anomaly, basically we are not going to perform because uterine anomaly is also one of the risk factor for malpresentation. So we don't know what's going to happen after we reverse it, but ECV has to be done always with consent. Okay, as we all know, ECV is not as such 100% safe procedure. There is a risk of placental abruption, fetal distress, bleeding, and so on. So always, whenever we do this kind of intervention, ECV and other breech extractions and so on, always we have to tell properly what we are going to do, and she has to be in line with our management. Okay, so I've never come across with two uterus, never in my experience, but hopefully it's possible to do the breech. I mean ECV for breech, unless there is something that obstructs us after we do the ACV. Is it recommended to do ARM for all prolonged latent to see the amniotic fluid? No. This question, it's a very good question. Yesterday, I have tried to mention something about amniotomy. Okay, amniotomy is always has to be done with indication. So for a woman with prolonged latent first stage of labor, the management is not artificial rupture of membrane. Rather, first thing is to assess what causes the prolongation of the latent. Is it power abnormality? Is it passage abnormality? Is it passenger abnormality? And then after doing so, based on the cause for prolonged latent, then you go for the management. For example, if it is macrosomia, we're not going to augment her, we are not going to do ARM, okay? We go for cesarean section, okay? If it is power abnormality, then definitely we go for augmentation, okay? But always we do ARM whenever it is indicated. For example, if we have some kind of fetal trait abnormality, we need to check for the liquor status, okay, whether it is meconium stained, bloody stained, and so on. So that is the indication to do ARM. But the membrane by itself is a good factor to dilate the cervix. So we don't need the membrane to be ruptured, okay, without indication. So it has to be done with indication. For prolonged latent, we don't. Is ECV actually practiced these days? Yes, it is very practiced in our hospital for breech, transverse lie, okay? Unless otherwise she has contraindications, we always counsel the woman, but it depends on the mother's willingness, okay? It's a very effective, by the way, very effective procedure in order to prevent cesarean sections, okay? So it is being done here and there. There is no, it is almost practiced elsewhere as well in the Westerns. Okay. But always, whenever we do ECV, we have to give a thorough analgesia for the woman, okay? Because it is a painful procedure, okay? And always, if we attempt and if it fails, we have to stop because the complications are higher. And also, after we do ECV, successful ECV, we have to monitor the fetal heartbeat for such a period of time because we might accidentally disrupt the placenta and so on and so on things. So always fetal heartbeat monitoring is very important after doing successful ECV. Is there any reading in our guidelines or textbooks that say multiparous women can't opt for cesarean delivery in breech presentation. Uh, Currently, we are always going for safe cesarean section. Okay, according to uh, guidelines, standard guidelines, society guidelines, and so on. The issue between primigravids and multiparesis is the capacious space of uh, the uterus and also tested pelvis. Okay, so if the woman has previous deliveries, it is tested pelvis, it's already dilated pelvis. Okay, we don't fear any complication related to delivery of breech presentation as such, as compared to the primipares. Okay, but in the premis, since it's not a tested pelvis, it is impacted uterus and so on. Okay, the risk of acquiring complication is higher. Still, it is a relative contraindications for breech delivery in premis. There are institutions that go for vaginal breech presentation in premis. Okay, in premis. Maltese, it is opted. It is opted for cesarean. There is no as such a clear cut indication to go for cesarean section in multipares, because the chance of delivery without complication is higher. Okay, so always we have to be on the safe side. The safe side is vaginal delivery. So we always go or choose for vaginal delivery rather than cesarean section. Cesarean section is not such an easy procedure as you see as every day. በሰላሳ ደቂቃ እንደምንወጣው አይደለም always. There are anesthesia related complications, wound infections, and so on things. So always we have to go away from those complications and near to safe procedures as much as possible. But always we need to give consent always. Okay, I believe giving a thorough understanding of the case for the woman. Okay, and it's better for the woman to choose what she likes, but always her understanding is going to be our understanding. እኛ የምንነግራትን ነው የምትሰማው እና always እኛ አንደርስታንዲንጋችን ጥሩ ከሆነ okay, the fact that she's going to understand and accept የማታደርግ ምንም ምክንያት አይኖርም። ስለዚህ that's my point here. Okay, since we cannot know onset of labor accurately, how we limit time for latent labor duration? There are books saying active labor after 6. Yeah. By the way, yeah, your guideline your previous guideline traction, 8 hours is going to be prolonged latent ብለን እንቆጥር ነበር። አሁን ላይ ግን we have to give ample of time for latents basically. Okay, ያው ትናንትናም ለማውራት እንደሞከርኩት 6 ሴንቲሜትር ላይ ነው ብዙዎቹ አክቲቭ የሚገቡት። almost 89% of women re-enter into active first stage of labor at 6 ሴንቲሜትር። ያ ማለት ሬት ኦፍ ሰርቫይካል ዳይሌቲስ ናቸው 1.2 እና 1.5 ሴንቲሜትር በላይ የሚሆነው ፐር አወር ከዛ ሴንቲሜትር በኋላ ከ6 ሴንቲሜትር በኋላ ነው። ስለዚህ ጊቪንግ አምፕል ኦፍ ታይም ፎር ላተንት ኢዝ ቬሪ ኢምፖርታንት ነው ተብሎ የሚታሰበው። but the thing that we take here is if a woman has rupture of membrane at the time of latent, that will make her at risk for chorioamnitis infection. So that time we have to be sure that it is not going to be more than 8 hours. Okay, so 8 hours is going to be our cutoff point to say prolonged latent first stage of labor. So the cutoff point of 6 centimeter, 5 centimeter, 4 centimeter is depending on studies. So basically we are currently adapting according to 2021 Ministry of Health guideline. Our guideline is taking 5 centimeter as active first stage. The other one is please repeat procedure of total breech extraction. So total breech extraction, what we are going to do is we are going to insert our hand totally through the cervix and we are going to decompose each and every part of the fetal part. መጀመሪያ እግሩን ቀስ ብለን ዲኮምፖዝ አድርገን እናወጣዋለን and then gentle traction apply እናደርጋለን and then ቦዲውን ወደ ታች እንስበዋለን and then gently we are going to deliver the hands. Okay, and then after finally we are going to deliver the head. That's what we call it total breech extraction, which means we totally extract it from the uterus. That's what it means by total breech extraction. So if a mother refuses destructive delivery post IFD is labor in or end is in labor and says that is her right. Okay, one ቅድም እንዳልኳችሁ IOFD ቢሆን the safest inexperienced hand የሚሆነው distracted delivery ነው because we're not going to put a scar on her abdomen for a baby that has gone. Okay, ስለዚህ safest የሚሆነው doing distracted delivery እና delivery ነው. But if she consents for cesarean section, that's her right. That's her right. And cesarean section is going to be done for her. How commonly you do CS in breech? What percentage breech go to CS? I'm not sure about this question. I don't understand what the question says, I think.
I think
Can you just elaborate how commonly you do CS in breech? As I have tried to explain earlier, breech with premise, it's a commonly done. These days, በተለይ breech with premise are being done commonly because of the X factors. But for multis, we always go for vaginal breech deliveries. But if the progress of labor is not successful, okay, or if she has any indication for cesarean section, we go for cesarean section. Maternal RVI, is it a contraindication? Yeah, basically we don't recommend to do ECVs and other procedures, like amniocentesis and so on procedures for vacuum deliveries and operative delivery, basically, okay, for a mother with RVI currently. I think I've gone through the questions, right?
Yeah, thank you very much. And yeah, we are also running a bit late, right?
Yeah.
Yeah, thank you very much, Doctor, on behalf of Blue Hills Ethiopia and all our participants, as well as Latent. We would love to thank you for taking the time to have a very elaborated and clear presentation on abnormal labor. And participants, as I have said earlier, you can find Dr. Dawit's previous Blue Hills virtual seminars on our YouTube channels. We will be posting them soon. So, Doctor, we hope we will be seeing you repeatedly in future sessions as well with related topics. And thank you very much. If you have anything that you would like to add, please do so.
Yeah, nothing to add. I really thank you for having me this presentation. Hopefully, I'm going to in touch with you with other topics, definitely. Thank you all.